Hello, how you doing, Ahmed? Can you hear me? Oh, okay. Well, can you talk to me, Ahmed? I need some information.
Hi, dear Prof. Can you hear me, dear?
Yes, yes.
Amazing.
Everything okay?
Yeah, I'm just waiting for a man.
Okay, okay. I talk to you later. I talk to you later.
Okay, as you want.
Okay. I'm just gonna work on a few things, right?
Okay. Good evening, joint minutes.
20 minutes?
What?
Yeah, 20 minutes, 15 minutes.
Okay, okay.
15 minutes.
I am waiting.
Okay.
Okay.
Well, you did a Zoom before, so you know what you're doing.
Back.
Oh,
Okay.
gotta change the screen. Okay, good. You got a good background. That's
Okay, good.
Yeah,
Good.
that's. Now,
joint minute. أحمد الغنمي.
introduce
Mac
to
host.
introduce.
What?
You want me to introduce the speaker? Do you want me to introduce
No.
you?
I am will reduce the lecture.
Okay, you introduce, right?
Okay. I will reduce the lecture.
Okay, I will introduce you. I say I am John Bennett, Neurosurgical TV, and I'd like you to meet Ahmed Ali, the director of this program. And
Okay.
that, okay? And
Okay.
then you do what you want to do. You do. You do what you have to do. Yeah.
Speak. Okay. Today. Today. We. Today. Will tartan Yemen. Hand collaboration. Neurosurgical TV. Hint to introduce. Prof. Mehdi Darmoul. Unilateral biportal endoscopy for lumbar hypoprolapse. Prof. Mehdi Darmoul works resident of Tunisian Neurosurgery Society and head of Montasser Neurosurgery Department Fatouma Bourguiba Hospital, Tunisia. Good.
Okay. Is this Walter Dandy or Yemen neurosurgical students? What organization are you? Are you
John,
is this Walter Dandy?
John, can I talk?
Yeah, go ahead. Go ahead.
Okay, I cannot switch on my camera, but anyway, it's just like uh, Abdurrahman just talked with me about his motivation and interesting in neurosurgery and to get a relationship with the neurosurgery professors from around the world. I told him, okay, that's okay, and it's good idea to go ahead, but yeah, it's like steps to go on. So I told him we have to start in Dani, Yemen, as in principle. I mean, then if we get, if we get more achievements and if we did good, we can go ahead to the next step to be in the Dundee Society globally. So
Okay,
now,
now is this the Walter Dandy Association, this talk, or
no, no,
no?
no, no. This time is for Dundee, Yemen.
What organization is it?
Okay, it's for Dandy Yemen now, but later in the next few months we will go ahead with.
So it's okay. Wait. It's a
Yeah.
Walter Dandy? Is it
Yemen.
what? It's a Yemen Walter Dandy, right?
Yeah,
Okay.
that's it.
That's no problem.
Mhm.
Abdelrahman Aliter. Abdelrahman Aliter. I got
You
that.
did great.
Yeah. Oh, here's the speaker. Where's
Mhm.
the speaker from?
It's from Tunisia.
Oh, from Turkey?
I am here.
It's from Tunisia, Dr.
Welcome.
Professor Mehdi.
I am here.
Okay. Oh, hello,
Good
Doc.
Okay.
Good evening.
Good evening, Prof. Mehdi Darmoul.
Thank you.
How are you?
Thank you. Thank you. Fine. Thank you very much. How are you?
Fine.
Okay. Okay. Thank you.
Hi, dear Professor Ramadan Kareem. I wish you all the best. And now we can say Eid Mubarak. كل عام وأنتم بخير, by the way.
Inshallah. Yes, we can say Eid Mubarak. Thank you.
Yeah, that's it. It's a great honor to have you, sir, with us tonight.
Thank you. Thank you very much. Thank you.
Hello, Dr. Darmoul. I'm Dr. Bennett of
I
Neurosurgical
was.
TV.
Welcome.
Mm.
Welcome.
Yeah, welcome to you, and thank you
Welcome.
for speaking.
Thank you. It's an honor for me to participate also with you.
Okay, this is a very
You
active
know,
group.
dear John.
Yeah.
I mean, yeah, you know, sir, Professor Darmoul is very famous globally and has attended many conferences around the world. So he is very well known professor around the world, and that's why we just uh, tried to get him with us tonight.
Well,
So,
excuse me, Ahmed. Why don't we have you introduce him, okay? Can you do that? Rather than
okay, I can.
Abdel, it's hard to understand. You know, I appreciate
Mhm.
that. I don't speak Arabic either, so, but can you
Mm.
introduce Dr. Darmoul?
Okay, but you can, I mean, I wish you can only
Okay.
to
Whatever you think is
tweet,
okay.
I mean,
I know the
to
internet
get
connection
the
is bad.
camera and to use my camera.
Yeah, I can see. Well, I think Abdel will do it.
Yeah,
I'll introduce
I'm not in the
Abdel.
ban list, by the way. I mean,
Yeah,
okay,
your internet's not it's a little shaky.
okay, it's up to you, sir. No problem. Let me just get
You are in Yemen now?
to
You
start
are in
from
Yemen?
أنا
You are in
me.
Yemen?
Do you mean me?
أنا
Yes.
أنا
Yes.
Whom do you mean,
لا
sir?
no هاي from Palestine but I study medicine in Egypt.
Egypt, yes.
Egypt.
And the TV, neurosurgical TV in Yemen?
No,
No, is
le,
very.
le, le, w- le, we can collaboration between Tent Yemen and Neurosurgical TV.
Okay, okay.
They've been with us a
By
long
the way,
time.
Professor, but Neurosurgical TV. Sorry for interrupt you, but I want to just
Yeah.
inform Professor that Neurosurgical TV is a global platform for neurosurgery events.
Yes.
So
Yes.
yeah, it's very active and very amazing platform for neurosurgeons, and
Mhm.
it's like the platform that many professors around the world get famous just with Neurosurgical TV. That's why we try to get Neurosurgical TV collaboration. I mean,
Okay.
But you are more active than most groups because I do other groups also. But
You are active also. You are active.
yeah, you've seen them. You've
Group.
seen Yemen, right? They're very active. It's
Yes.
late, especially lately, right? Lately, well, now you have
Mhm.
two different webcasts. I guess the Walter Dandy and the Yemen Neurosurgical Society. Is it? That's correct,
Mhm.
right? Okay.
Mhm.
Okay.
Okay, we got a few minutes. You know, don't let the numbers fool you. A lot of people watch this on YouTube right now. Because I can tell because when I check the statistics of the website, I
Mhm.
can tell they're going to YouTube
Mhm.
to watch this because it's live, but it's live
Yes.
on YouTube also. So
Yes. I live in YouTube also. Yes.
yeah, it's in both. So
In both. Okay.
yeah, so you believe me, there's a lot of viewers, 70 to 100, I would estimate.
Okay.
Generally,
Very
that's
good. Yes.
that's what
Good
it
number.
Very
is.
good.
So you're not wasting
Very
your
good.
time, Doc.
200 at least. Good number.
Okay.
When we will start? In 2 minutes?
Yeah, just
Oh,
we can start now. We can start now.
In 2
Okay,
minutes?
okay. Wait, let me
okay now.
introduce. Hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. This is John Bennett, broadcasting from the home of Neurosurgical TV, Miami Beach. We have the pleasure of having a very active group, the Walter Dandy group of Yemen. They're doing lots of webcasts lately, and I'll introduce the director of this organization, Abdel Rama Aliter.
Okay. Today, Prof. Mehdi Darmoul will talk about unilateral biportal endoscopy for lumbar hip prolapse. Prof. Mehdi Darmoul works resident of Tunisian Neurosurgery Society and head of Muntasir Neurosurgery. Okay. Okay.
There is problem in the sun. In the sun. Sound.
He didn't finish his introduction, correct? Abdel, are you okay? Your connection is a little shaky. Okay, Dr. Darmoul, well, okay, why don't we go ahead and you can start your presentation and thank you for coming.
Thank you.
Yeah, can you start your presentation,
I
please?
can start?
Yes, please.
Thank you. Thank you
No,
for your kind invitation. It's my great pleasure
I
to
think
participate to this webinar. And thank you very much. I will talk about, I share my screen.
Go ahead.
Oh,
I will share my screen.
you can
Okay.
share.
No, you're not
Share,
sharing the screen yet. Not yet.
okay.
No, you're not
Share
sharing the
my
screen.
your share.
Mhm.
Okay. There, okay. Okay, make it full screen, please.
Is it okay?
No, you have make it perfect.
Mhm. I can start.
Yes, please.
Yes.
Good evening, everybody. Good evening, and thank you for your kind invitation. And thank you for the moderator. Dear moderator and dear participant, I will talk about unilateral biportal endoscopy for lumbar disc prolapse. UBE is a novel minimal invasive surgery technique which is actually increasingly and widely performed due to the progressive development of the endoscope and the specialized surgical instrument. It shifts the point of visualization away from the surgeon's eye or microscope and places it directly at the site of the spine pathology with an endoscope. It allows the visualization of the spinal structure via two small incisions on one side of the spine, minimizing tissue injury and enhancing postoperative recovery. Initially, it was used to treat disc herniation, but actually it can treat a wide range of spine pathologies. But this technique requires specialized training and instrument, and for beginner, a steep learning curve is mandatory. A brief reminder of the founders of the spine endoscopy. Faubert and Caspar in 1991 introduced the metallic tube for endoscopy, and Destando in Bordeaux, France also introduced in 1990 the endoscope called endospine. In 1997, Foley and Smith did the first endoscopic microdiscectomy, and more than 10 years, Dr. Sun from South Korea developed UBE, which was rapidly growing and popularized first in China and now in all the world. Why UBE? Donc, UBE, we will do UBE. There are four goals. The first goal is to reduce the muscle dissection and intraoperative bleeding. The second goal to reduces postoperative pain and medication consumption. The third goal, it reduces operative time and shortens hospital stay. And the last goal, the fourth goal, it lowers the risk of infection and faster recovery after surgery with less rehabilitation needed and early return to work. What are the indication? The main indication and the first indication is lumbar disc prolapse, then lumbar stenosis, unilateral foraminal stenosis, cervical stenosis, thoracic spinal stenosis, ossification of ligamentum flavum, coda equina syndrome, severe disc degeneration. And in the right side, in this journal, the author classified the indication among the region. In the cervical spine, UBE is indicated for unilateral foraminal stenosis, especially if refractory pain, in case of refractory pain to conservative treatment or progressive neurological symptom. In cervical stenosis, less than 50% of the spinal canal. In the thoracic region, donc it is indicated in thoracic spinal stenosis, in ossification of ligamentum flavum, in synovial cystis. In the lumbar, indicated in herniated lumbar disc, coda equina syndrome, lumbar stenosis, modic change in vertebral underplate, level 2, severe disc degeneration, grade 3. There are also contraindications. There are relative contraindication and absolute contraindication. For the relative contraindication, spinal stenosis with disc herniation more than 3 levels, fused type of ossification of ligamentum flavum, severe dural ossification, severe stenosis, grade 2 or higher spondylolisthesis, postoperative lumbar stenosis, bilateral foraminal extraforaminal stenosis, and vertebral fracture. For the absolute contraindication, especially central lesion, segmental instability, high-grade deformity, infection, tumor, vascular malformation are contraindication of the UBE. what are the difficulties? To manage the difficulty, the surgeon should have advanced surgical expertise and should have also do steep learning curve. And this difficulty are due to lack of tactile feedback and difficulty achieving anatomical orientation due to the narrow surgical corridor. The technical principle of this technique, UBE, utilizes two skin incisions referred further as portal. One portal you make is called the viewing portal. The other one is called the working portal. Your non-dominant hand inserts an endoscope and your dominant hands use the endoscope working portal. This is two portal. And there is a checklist, the checklist of practical tips to ease your journey into mastering UBU. First step, after anesthesia, always position your patient on prone on spine frame. The second, you should have a special drape, endoscopic spine surgery drapes for the UBE. The third step, you should have endoscopic tools, irrigation technique. And the fourth step, you should always triangulate your surgical instrument under C-arm fluoroscopy guidance. This is the endoscopy column, the tools, the instruments, the tube to do this UBE for spinal disc herniation. When to start UBE? UBE takes the level of spine surgical. The surgeon, neurosurgeon, the beginner should, for UBE, should have a level of spine surgical maturity before he enter into the technique. He should do open spine surgery and then microscopic spine surgery, and in the end, he will turn to UBE. One should be ready and competent to convert UBE to microscopic spine surgery in face of a complication. Now I will describe the surgical technique. The surgical technique generally done under general anesthesia on prone position with the abdomen free over the radiolucent frame. We can use Wilson frame or Jackson table or other table. The skin and the surgical field are prepared in the usual manners. The final layer of draping is waterproof, and the smooth drainage system for the saline outflow is properly set up. The biplanar fluoroscope tilted parallel to the disc space. The spinal level is marked on the skin. UBE requires two small incisions through the deep fascia, a smaller one about 5 to 6 millimeters for insertion of the endoscope and continuous normal saline irrigation. And the second one is a larger one, about 8 to 10 millimeters for the outflow of normal saline, and also use it as the instrument portal. An endoscope of either 0 or 30 degree is used. Here we use the interlaminar approach through the medial pedicle line and distant from the medial line 1 centimeter, and we will work between the lamina of the upper vertebra and the lamina of the lower vertebra. Here we will show you one of my patients on ventral position, prone position. And we will draw 3 lines, 2 vertical lines, one the medial line in the medial line, and one in the medial pedicle line, and one horizontal line in the disc in which we will work. And we will do under fluoroscopy this landmark. The two skin incisions usually located along the medial pedicle line, 2 to 3 centimeters distant, 2 to 3 centimeters. The working scope is at 9 to 10 millimeters, and the endoscopic portal size is about 7 millimeters. We use serial dilator up to 10 millimeters to split the paraspinal muscle, enlarge the instrument portal, and gently detach the soft tissue of the interlaminar space. The muscle should be detached from the lower border of the cranial lamina at the pathological level to the upper border of the caudal lamina. It is performed by using a radiofrequency probe and removing soft tissue with a muscle shaver. The endoscope and surgical instrument are triangulated. The outer layer of ligament flavum and bulky soft tissue should be removed using a Kirsten patch or pituitary forceps to confirm the landmark of the laminectomy. And a 3,000 milliliter saline bag is placed 80 to 100 centimeters above the patient's back, and with a pressure of about 100 centimeter water injection pressure, or an automatic pressure pump, which can be used. Water pressure should not exceed 30 millimeter Hg if possible, and this allows the irrigation fluid to create working space. This is the landmark on the AP radiograph. An endoscope portal incision in the left side, and in the right side, an instrument in the right side of the surgeon, instrument portal, and distant from each other 2 to 3 centimeters, and distant from the midline 1 centimeter. And you should triangulate your instrument. The tip of the instrument, the endoscope, and the working instrument should be triangulated. We should do meticulous hemostasis, and the surgical procedure is in a clear and magnified surgical field. Hemostasis for bleeding from small epidural veins and oozing from bones can be achieved by adjusting the inflow hydrostatic pressure and control of outflow. Bleeding from soft tissue and larger epidural veins can be cauterized efficiently by radiofrequency. Bone wax is useful for stopping more severe bleeding from cancellous bone. You should start the decompression from the spinolamellar junction using an electric high-speed diamond burr of 3 or 4 millimeters in diameter. We will drill the ipsilateral lamina from its lower margin cranially until the origin of the ligamentum flavum and underlying epidural fat, which are exposed. We separate the ligamentum flavum from the dura. We will see all these steps in the video after. We will retract the dura and the root to discover the disc prolapse, and we will remove after the disc prolapse. At the end, the root will be free, and we finally do foraminotomy, and we should ensure a good hemostasis. And at the end, we insert a small caliber suction drain tube with a diameter of 10 millimeter at the end. I will show you this video. First, we will do the marking, skin marking, and the skin incision in the working portal. We use dilation and muscle detacher. And we will do a second incision for the endoscope portal. And the instrument should be the tip triangulated of the instrument. Here we insert the saline to create working space. And we start to travel after cleaning the soft tissue and the outer layer of the ligament flavum. We drill the inferior border of the lamina of the upper vertebra, and here, after thinning the lamina with the drill, we can use the Kerrison from caudal to cranial until till the insertion of the ligament flavum. And the radiofrequency is used to for the hemostasis, for the bleeding. In the AP view, here, the removal of the bone. In some cases, we can use it for the contralateral side. After we remove the ligamentum flavum, and we reach the disc, we will open the entrance by cutting into the outer surface of the disc. And we forceps we for grabbing out the disc nucleus. Technically, this is the technique, and I will show a video of the here one of my case after the patient on prone position after dripping, and we did the landmark, three line, one medial line, one line through the medial pedicle line and horizontal line in the disc space in which we will work. And we do two incision, one for the endoscope and one for the instrument. And here in the we'll do after the fluoroscopy showed that the tip of the instrument we triangulate the instrument in the spinolaminar junction in the inferior border of the lamina of the upper vertebra. And here we will do two skin incision in the one side, E portal in one side, in unilateral one side, and here we will start the working with the endoscope, and here with the radio frequency we start for cleaning the soft tissue and the outer layer of the ligament flavum to expose the inferior border of the lamina of the upper vertebra for drilling. And here we, after removing the ligament flavum, we expose the dura. And here, after we retract the dura and we see the disc, the disc. We show you a video of this technique. Here with the endoscope, we see we will here we are cleaning the soft tissue and the outer layer of the ligament flavum to expose the inferior border of the lamina of the upper vertebra. We start by drilling the lamina of the upper vertebra here in disc prolapse in L4, L5, disc prolapse in the left side. The endoscope is in the left hand of the surgeon, in my left hand, and the radio frequency in the right hand, the instrument in the right hand. Yeah, we are cleaning, and you see that there is no bleeding, and the field is clean. Because we have the saline, the inflow and the outflow of the saline. We'll clean all the soft tissue and the outer layer of the ligament flavum to expose the inferior border of the lamina of L4 here. We are cleaning with the radio frequency. We can also use the forceps for cleaning the soft tissue, the forceps or a kerrison. Here, after cleaning, we will drill the inferior, we expose the inferior border of the lamina of the lamina of L4 vertebra. We will drill here the inferior border till the insertion of the ligamentum flavum, and we will detach the ligamentum flavum. After thinning the lamina with the drill, now we are do hemostasis with radio frequency. We can use the kerrison here to rapidly remove the bone till the insertion of the ligamentum flavum, and we will detach the ligamentum flavum from the lamina, and we will expose the dura till the edge of the ligamentum flavum. We'll drill. Here we will enlarge this space with the kerrison. We see the dura. We enlarge with the drill. We do hemostasis. We will detach the inner layer of the ligamentum flavum. We'll remove it to expose the dura and the root. We'll do some hemostasis, and we can use also the radio frequency. Here with the kerrison, we'll detach the ligament flavum, and we'll expose the dura and the root. You can see the dura, and here, after exposing, we see the disc prolapse. In the lateral side, the disc prolapse. We will retract the dural sac and the root, and here you see the disc prolapse. We will open this and remove the nucleus from the disc. This is the disc prolapse exposed. Will open. Here will open, and you see the delivery of the herniated disc. And with the forceps, we will complete our dissectomy to remove the free part of the disc inside the disc, the free part of the nucleus pulposus inside the disc. We enlarge the opening. This is the part of the root. A small bleeding can be managed by the inflow and the outflow of the saline. Yeah, we will enlarge the opening of the disc with the radio frequency and the disc forceps to remove more fragment from the disc. With the forceps now. We'll remove all the fragment, and we will decompress, do a good decompression of the disc. And here the root and the dural sac is free from the compression at the end. To do this technique, the learning curve is mandatory, and the learning curve for UBE surgery takes time and requires practice at least 20 to 30 cases. Step by step, system can make learning curve shorter. You should know that there is also complication in this technique, like dural tear, which is encountered in up to 4.5% of cases, and complete decompression in 2% of cases, transient palsy in 2.6%, epidural hematoma in 1% of cases, and infection, surgical site infection in less than 1% of cases. Endoscopic discectomy, how to start? You should register in a program of training. You can apply for a fellowship program. You can register in a cadaver course, in a workshop simulation, in online course, do short-term overship, and you can invite the faculty, expert faculty in this field. How to start? Before starting, a good knowledge of surgical anatomy is mandatory. Also, a good knowledge of orientation of X-ray in this region. You should have previous experience in spinal surgery. At least you should do open spinal surgery, and also if microscopic spinal surgery, if possible. You should select your patient in the first cases. You should do this technique with a slim patient with a good disc prolapse, a big, huge disc prolapse in L5S1. You should also select your team, who will help in this technique, and also you should be supported by faculty if you have all this. You can go and do this technique. You can start this technique if you have all this selection. And in conclusion, UB is an innovative surgical technique. It is a powerful surgical method for the treatment of lumbar disc prolapse. It can treat all kinds of disc disease, and it is more clean than microscope. No bleeding, as you see, no bleeding than microscope. It is a safe technique and effective alternative for treating various spinal conditions with reduced pain, faster recovery, and a lower risk of complication. It improves the patient's quality of life, and actually, you should know that it is an important advance in the field of spine surgery. And you should know this technique, and you should start if you follow all the conditions listed before. And thank you for your attention. If you have any question for the participant, if there is any question, I can respond.
أيوة. دكتور محمد سوار ask for question. Question one. His is the target point is the same in Hill HD hand stenosis?
For the central stenosis, yes, but for the lateral in the recess, not the same. Not the same. The target not for in the paraspinal region. For the central stenosis, the same, yes. But for the lateral stenosis in the foramen, not the same, not the same target. in
أيوة، أوكي.
foraminal or extraforaminal compression, herniated disc or stenosis, foraminal stenosis, not the same target.
Okay. Question 2. Which side are you standing on if the hernia is on the right side?
In the right side. We stand in the surgeon should be in the right side.
Okay.
For the disc prolapse, for the hernia, but for the simple hernia. But in some cases, for not simple, for we can say in the contralateral side, we can do it.
Okay.
In some cases, not for all cases. In some cases, migrated, and we can.
Okay. Thank you very much, Prof. Mehdi Darmoul. The presentation wonderful and beautiful. We are happy to connect with you.
Thank you.
Thank you.
Thank you very much. You, they understand all the lecture, the student, or they have more question? Because it is a new technique, not standard.
Understand.
But the principle inside for removing the disc are the same than the standard technique. But to enter to the disc and it is different.
Okay. John Bennett سؤال.
Is there other question?
No.
Which do? There is another question. Do a surgeon needs to be an expert in arthroscopy before starting UBE? Not, he's good if he is an expert in arthroscopy because the same technique. If you know arthroscopy, you are the learning curve will be shorter than another surgeon. Sure. It's good if
Good,
but
good.
it's not mandatory.
Good. Okay. Dr. Habib
Yes.
Abdullah asked two questions. Question 1, do a surgeon needs to be an expert in orthoscopy before starting
Yes, I respond to
unilateral
this question.
bipolar
Yes,
endoscopy?
I respond. Arthroscopy, no, not mandatory, but he is good. If he had knowledge on arthroscopy, it is good. The learning curve will be shorter.
أيوة. Okay. Question 2. Can we do transformational approach via UNE?
Yes, UBE. We can do. We can remove foraminal hernia by UBE. But the target is not the same that we for lateral for simple herniated disc. There is another target, but we can do it by UBE. Yes.
Okay. Question 3. How about for lateral syndrome.
Far lateral syndrome.
Yes.
For extraforaminal hernia, he mean?
Me. Oh.
Yes, I said that we can do all kind of disc pathology with UBE, all kind. For lateral, paramedian, far lateral, we can do all, but the target is not the same.
Okay.
The entry point is not the same.
Okay. Question 3. Can this technique be used in cervical and thoracic spine?
Yes, yes. In the indication, I said that we can use in cervical, thoracic, and lumbar. In cervical, especially in stenosis, especially if stenosis less than 50%, we can use this. And for unilateral stenosis, also we can use in cervical. In thoracic, also for stenosis and for ossification of ligamentum flavum, we can use it. And in especially we can use it in lumbar also. The first utilization was in lumbar for lumbar disc herniation and lumbar stenosis.
Okay. Question 4. What makes or have refer it over the usual endoscopic approach?
What?
What makes you prefer it over the usual endoscopic approach?
Endoscopic because it's safe and we minimal invasive and we conserve the muscle and there is there are many advantages for this fast recovery and the daily surgery and the patient can go home in the same day and it's there are many advantages in the endoscopic approach.
Okay. Question 5. What are you doing if there is or there?
Is there?
What are you doing if there is or there?
Duratir. Yes, duratir.
Okay.
We can, if there is a complication, we can translate to open surgery or to microscopic surgery. We can do if there is complication. Yes, no problem. We should manage the complication. If we cannot manage by in UBE, we can transform our approach to another to microscopic. Also, or microscopic better is also mini invasive surgery.
أيوة أوكي. دكتور أحمد الغنمي.
Dr. Ahmed, where is Dr. Ahmed? You want to talk or ask?
Do you speak Arabic, Prof. Mehdi Darmoul?
Yes, yes, I speak. نعم أتكلم العربي.
تحكي عربي؟
بالتونسي العربي نعم أتكلم.
أيوة. بل شو اسمه تونس تحكوا يعني باللغة العربية الفصحى يعني.
بالعربية، أي بالعربية
أيوة
وبالفرنسية أكثر شيء، عربية
أيوة
وفرنسية وشوية
نص نص.
إنجليزية، شوية مش كثير.
مم. آه مم. ال- أنا بدرس الطب
دراسة
في.
بالفرنسية، ميدسين
أيوة
بالفرنسية.
أيوة ال- أنا بدرس الطب في مصر، لكن أنا من فلسطين يعني.
مرحبا مرحبا بك.
أهلا
أهلا وسهلا.
أهلا وسهلا فيك دكتور أحمد. أهلا وسهلا
شكرا
فيك
شكرا
دكتور مهدي.
شكرا شكرا.
أوكي يبدو إنه فيش أسئلة عندهم.
خلاص معناتها فاهمين
أوكي.
بوحي التكنيك.
Okay.
خلاص شكرا شكرا. Thank you very
Yeah,
much.
thank you for taking your time,
Thank you
your
very much.
valuable time. Thank you for
Thank you.
educating. Thank you for
Thank you very
educating.
much for your kind invitation.
Okay, okay, good day. Okay,
Okay.
I'm gonna go